Good morning, everybody. My name is Frank Parham. I'm Senior Ergonomist and Inspector with the Health and Safety Authority. And I'd like to... Good morning, everybody. My name is Frank Power. I'm from the Health and Safety Authority. I'm a Senior Ergonomist with the Health and Safety Authority. I'd like to welcome you all here today and thank you for attending third in our series of practical ergonomic risk assessment webinars. Before I kick off, I'd just like to go through a few housekeeping items for today's webinar. The first thing I'd like to mention is that my colleague Barry Devitt has just put a number of links in the chat function there. There are 3 links there. One is a link to the EU OSHA campaign on MSD prevention for 2020 to 2022. The second one is a link to the MAC tool, which will be a relevant link to download for today's webinar because you'll be using it later on when Ita Leyden carries out the workshop in regard to using the MAC tool. And the third link that's in the chat function is a link to the Ergonomics webpage on the HSA website, which has a number of different guidance documents and risk assessment videos and links which are worth looking at. Other things I just want to mention are that at the end of today's webinar, there will be a survey. As you leave the webinar, there will be a survey, and we would really like if you fill that out, because for our purposes, it's very useful to get feedback on our actual webinars to see how we can improve going into 2022. We'll also be doing a recording of today's webinar, which will be available on the HSA website in the next couple of weeks under the events page on our website. With respect to today, before I go through the agenda, I just want to point out that if you want to ask a question, we have a chat beside the chat function in the bottom right corner. You'll see 3 dots, and if you click on that, you'll see a Q&A icon there. And if you go into Q&A and type in your question there, and at the end of the session, after Ita's presentation, my colleague Barry will go through those questions, and the panel will come up and we will go through those questions, and we would definitely welcome as many questions as possible, because it's through the question and answer session that we do learn a lot, and we found that so far. So in relation to the actual webinar today, the agenda, I'm just going to give a short briefing at the start, just to give you an overview of the context of where we're coming from with respect to these risk assessment webinars. Then I'm delighted to have on board for today's webinar Anthony Byrne from the National Ambulance Service, and Anthony will be presenting on a case study with respect to manual handling risk management in the National Ambulance Service. And then we'll kick off then with the final part, which is the introduction to the manual handling risk assessment charts, which will be carried out by Ita. And that's a very practical session, so we'd ask you to get involved in that very much so. So if I just go on in terms of my own presentation and what we're talking about managing ergonomic risk. So we're talking about strategies and interventions within the Health and Safety Authority and externally on how we manage these risks, because the reality is we have a lot of work to do in terms of managing these risks. With respect to the particular aspect of manual handling, employers are duty bound to manage manual handling risk, whether it's handling of animate loads or inanimate loads. So to do that effectively, they need to understand the activities that take place in their workplace where potentially there could be exposure to manual handling risk. They need to be able to collect technical information, including information like load weight data, information on their work area setup, postures, work environment. These are all key parts of the risk assessment process, and data collection is critical to good quality outputs in terms of risk assessment. Need to be able to use evidence-based risk assessment tools to identify risk factors, and then based on what we find in terms of our risk assessment process, to put appropriate measures in place to address those risks. And again, this all stems back to the principles of prevention in the regulation, which talks about avoidance of risk, evaluating unavoidable risks, and adapting work to the individuals. So we're talking about ergonomic risk management, and what we're talking about here is a number of things that need to be visible and evident. And these are things that our inspectors, again, are familiar with at this point, and I'll speak about that in a few minutes. But inspectors will be asking questions around this, in terms of getting an idea if there are potential manual handling risks in a workplace setting. Is there evidence that management are committed to addressing those risks? Is there evidence that there are resources available? We need to ensure that those responsible for designing workplaces and managing workplace setups are understand the importance of managing these risks. We need to take steps to understand the nature of work carried out in the workplace. That might seem like an obvious thing, but in a lot of situations we do see that it isn't as evident in risk assessment documentation that we would see, and in terms of solutions for addressing risk exposure. And then we need to, as part of a good ergonomic risk management approach, there needs to be a development of competencies in managing these ergonomic risks. So there are tools available. The Health and Safety Authority certainly promotes the HSE tools, the MAC tool, the RAP tool, the R tool, because they're evidence-based tools. And we feel that these are appropriate tools to be used in workplace settings. But people need to become familiar with them, and certainly if they can get training and are used, even better. Developing innovative engineering organizational solutions, communicating and consulting with staff, and then also looking at implementing appropriate change in the work practices, and making sure that people are aware of what those changes are, why those changes have been put in place, and what are the benefits from the employee health point of view. So we have risk management, but there is a legal context to this. We have the 2005 Safety, Health and Welfare at Work Act, and the hierarchy of controls. And within the legislation, the Act, it very much underlines the importance of providing safe systems of work, designing and maintaining a safe place of work, consultation. It's all in there. But we also have the manual handling of loads regulation, which talks very much about identifying where there are work activities that involve risk, and then looking at how you're going to manage those risks. And then we have the display screen equipment regulation, which we spoke about last week at our webinar, with respect to, particularly at the moment, with respect to remote working, where there's a lot of significant impacts there, and the importance of managing those risks there. So if you look at all those pieces of legislation, they have a lot of things in common. They talk about risk management, avoidance of risk, prevention of risk to health at work, adapting work to the individual, using appropriate means to avoid or reduce risk, and evaluating unavoidable risks. So with that in mind, we then look at how this practically should happen in workplace settings. This is a case study. We're going to be looking at healthcare in a second. I have a few examples from healthcare, but this is just one. It's a case study where we were involved with a company. They had an issue with manual handling. So the first thing is the task description, with what exactly is happening here. So this guy is basically handling a part and transferring it into a machine for machining. The part is very heavy. It's up to 75 kgs in weight. There's lots of posture issues here in terms of bending and twisting at the same time. So there are significant risks here. So the risk exposure is really important here. And this is a point I've made at a number of the webinars so far. Sometimes we get very hung up on looking at KPIs or key performance indicators that measure risk in terms of accident rates and illness rates. But what we really need to do, particularly around these risks, we should be measuring risk exposures. What are the number of risk exposures we have? What are the level of risk exposures we have in our workplace? And this can be done through using risk assessment tools like the MAC tool, which you'll learn more about later on with Ita. But if you look at this example here with this particular task, we can see straight away that there are 4 significant risk exposures. Load, weight and frequency, it's a purple, which is a very high risk of injury. Hand distance from the lower back is red, which is high risk. Trunk twisting and bending, red, high risk. And then we have grip on load, red, high risk. So there's risk exposures there. It's foreseeable that there could be a risk of injury. So then the employer is obliged in that regard, not just from a moral point of view, but also from a regulatory point of view, to manage those risks. And what they did was they came up with a solution, an engineering solution to address those risks. The idea for this solution came from the individual that's in the photo that you see there. So that eliminated a lot of the risk exposures. So if you eliminate a lot of those risk exposures, then you're eliminating the risk of an injury. So, so that with that in mind, and what has been happening and the regulation, we recognized a number of years ago that we needed to kind of emphasize and refocus attention on risk management, because albeit we have done work in relation to developing training standards around manual handling training and instructor training. Training is only one intervention, and it's not the most important intervention in terms of managing ergonomic and risk to musculoskeletal health. the risk management approach in terms of avoidance and adapting work to the individual is paramount in addressing these risks. So the Health and Safety Authority has developed a strategy around managing occupational health risks in the workplace. And part of this is to increase knowledge and understanding of occupational health risks, raise important awareness around the value of managing and controlling these risks, and then ensuring legal compliance through proportionate enforcement. So we've done this in a number of ways. We've developed inspector competency in addressing these risks. Over the last 8 years, all our inspectors, field inspectors, are out at workplaces every day of the week. They've all been trained on the use of the risk assessment tools developed by the HSE UK. And these training sessions are provided by the HSE UK themselves. So it's good because it means that our inspectors are getting a feel for how these tools are used in a kind of a workplace setting in the UK, because it's the same kind of legislation and it's the same risk factors. So so one of the reasons there's a number of reasons why we wanted the inspectors to get this training. One of them was to understand the tools, but also to allow them to ask the right types of questions when they were out doing inspections. So we've also been involved over the last 5 years in organising risk assessment workshops and webinars, which is what we're doing today, because we want to get the message out there that, you know, we want to see more use of these risk assessment tools. We want to see more good quality outcomes in terms of managing these risks. We've also developed our own guidance over the last number of years. The guidance there in the middle, again, these are all available on the links that were sent out to you by Barry. Managing ergonomic risk in the workplace. There's a very relevant bit of information, page 14 to 18 in that document, outline the risk assessment process, 5-step process, incorporating the use of these risk assessment tools that we're talking about here today. And I would urge you to download that if you're looking at these issues in your workplace. And then we have looked at case studies of good practice, and these two quick case studies here are specific to the healthcare sector. We had David Donoghue speak at our webinar last week on work that was carried out at the National Rehab Hospital in Dunleary. And this was a very innovative case study, because what they did as clinical experts in physiotherapy, occupational therapy, they actually got involved with the designers, the engineers, in the build of a new hospital, the new ensuite bathrooms in the new hospital, so that they could I suppose, give input in terms of what their needs were and what the patient's needs were, so that they could address not just patient needs, but also user needs or worker needs in terms of reducing exposure to musculoskeletal health risks. We also have a case study on the National Ambulance Service, which Anthony's going to talk about in a couple of minutes. We've also been involved in looking at inspections in the construction sector over the last couple of years, specifically in the construction sector and health sector. There were kind of priority areas, and we looked at, you know, different hazards. But one of the areas that we looked at in healthcare was manual handling and risks, and not specifically patient handling in this case, but more handling of inanimate loads. And we did a lot of work in 2019. Unfortunately, last year, due to the pandemic, a lot of that work was put on hold. But we did find out a lot in 2019 in terms of what was going on. We found out that not all hospitals had a dedicated health and safety function. They're very large workplaces with many challenges and many different kinds of work activities going on there. We were, you know, interested in getting information on the range of departments in the hospital and the range of activities. Risk assessment documents for manual handling were general and generic in most cases, and they needed a lot of attention. So the kind of information that we needed and we didn't see in many cases was information on the task description. There was very scant information in terms of weights of load, posture, space, information on, you know, how they documented the evidence of risk factors and evidence of task-specific improvements to avoid or reduce risk. So these are areas that we addressed with specific workplace healthcare environments during the inspections, and is also work ongoing. So what we found was that the TILE checklist, that is the task, individual, load, environment checklist, was used a lot. So there was questions in there like, you know, for example, is the load too heavy? And it might have said yes, but there was no evidence as to why it was heavy. What was the information to support that answer of yes? So that's why we were kind of, I suppose, pushing for a more specific risk assessment model, which collated for, you know, information that was relevant to informing whether or not there was risk exposure. So there was a lot of use of standardized risk assessment metrics like high, medium, low, which made no reference again to the risk factors. So there's work to be done there. There's, notwithstanding that, then we came across some very good examples of interventions in certain areas as well. But these are things that we're conscious of and we're going to work on with the healthcare sector. Other findings were, that we looked at different tasks to get a better idea. This is just examples of some of the tasks we came across. Handling transport boxes for specialized tools used in surgery, handling isolators while scanning, lifting heavy lead parts in radiology, laundry handling, maintenance activities, handling bags of salt, handling oxygen cylinders, catering activities, housekeeping, medical records, pharmacy, barcoding. So the whole range of different activities there. And really what we're saying is we'd like to see more specific risk assessment using evidence-based tools with respect to those types of tasks. So going into 2022, we hope to be doing more interventions in the healthcare sector, more inspections and consultation with the sector. We'll be looking at more specific webinars for the healthcare sector around the risk assessment tools that we're talking about here today. We'll probably look at more guidance, specific guides for that sector. And then we'll be looking for increased management commitment or recognition of the need to manage these work-related health risks in an effective way. And then we'll be looking to see how healthcare sectors map out different functions and departments within a healthcare organization to determine, where potentially there could be risk exposures. So that's, in a nutshell, what we're doing with the healthcare sector, and it's kind of gives you an idea of the strategies. So these are the kind of questions our inspectors might ask when they come on site. Like they might ask what type of manual handling activities are being carried out, where are loads being handled, and what are the steps involved? Have you information on the load weight specifications? Can you provide evidence, documentary evidence that ergonomic risk factors are being identified and managed? And can you provide evidence that ergonomic risks are managed by using appropriate handling equipment or changes in the way work is carried out? So, those are useful questions to keep in mind if you decide that you're going to look at how managing these risks. In terms of the workshop today, the webinar, I'd recommend that after the webinar today that you take the tools away and try them out, use them, maybe get some training in how they're used, more specific training. Take a step back and look at the types of work activities in your workplace where there may be risk exposure. Don't be afraid to refer to our website and the links we've given you. And finally, just enjoy the webinar. So that's really all in terms of my overview. What I'd like to do now is I'd like to introduce our next speaker, actually, who's Anthony Byrne from the National Ambulance Service. So Anthony, if you just want to maybe put on your camera there and unmute, and you will put up your presentation. Anthony is a Quality Safety and Risk Manager with the National Ambulance Service South, with responsibility for quality patient care and occupational health and safety within the South area of operations. So that incorporates a lot of the Southeast. It also encompasses representing the National Ambulance Service with interagency and HSE emergency management. So we're delighted that Anthony's here today to present on this case study that we were involved with the National Ambulance Service in working on. So Anthony, I'll hand over to you. So thank you very much.
Thank you very much, Frank. Good morning, ladies and gentlemen. As Frank said, I'm Anthony Byrne. I'm Quality Safety Risk Manager with the National Ambulance Service South. This case study using a McIntyre tool, I was involved at a different level at that stage. My colleague Mary Houlihan was Quality Safety Risk Manager, National Ambulance Service South at that stage. But I was the Education and Competency Assurance Officer for the area, tasked with the rollout and education of the LifePak 15 monitor defibrillator in 2015. This is a single platform that the National Ambulance Service had procured on a procurement process, and working with the service provider and the company, I developed a training package, clinical training package for our practitioners to use. The rollout was in the National Ambulance Service Southeast area of operations initially, and the programme of education then was going to be trialled and then used nationally for the rollout of the LifePak 15 monitor defibrillator, which was a single platform coming away from 3 or 4 platforms we had within the service at that stage. Excuse me. Oh, apologies now. My controls are not working. So the work we do as a National Ambulance Service. Okay, the work we do as a National Ambulance Service, we are the statutory provider for the Irish state for except the Dublin metropolitan area, provide emergency ambulances to the general public and immediate care services, patient transport. In regard to cardiac related calls, we do approximately 30,000 calls on average per month within the service, and 10 to 15,000 of these would in some case be related to cardiac related calls or cardiac related symptoms and signs that the patient would display. But in generally, we would use the monitor defibrillator to assess patient vital signs, which is your ECG, end-tidal CO2, your oxygen saturation, and also blood pressure as part of our assessment of the patient. As I said before, prior to this, we had 4 different versions within the service of monitors with all different functionalities. Because of the evolution of emergency medical services within the country, we're now starting to use bypass protocols. And because of these bypass protocols, we need to be able to transmit ECGs to primary cardiac primary cardiac intervention hospitals and then transport the patient to that. So it meant that a longer travel time for some of our areas of operation. That is the reason why the National Ambulance Service went for a single platform that could send ECGs via a modem to the receiving facility, which would get a reading of the ECG, and then obviously they would bring the person to the cath lab, as you call it, and then intervention would begin straight away on time of arrival. The monitor picked was the LifePack 15 monitor defibrillator, which encompassed a lot of things that we required, including the modem and the ability then to store that information in a data center for future reference if needs be. The issues then, we began following the rollout of this. It was a very quick rollout in that the old monitor was taken out of the vehicle and the new monitor was put in with all its charging points. To facilitate this, it was put in the old place within the vehicle itself, and that picture will be coming up soon to do that. But it soon became identified by crews working on the road that there was a high risk because of the weight of the monitor, which was 15 kgs compared to our old monitor in the southeast, the Philips MRX, which is 10 kgs. Its position within the ambulance itself, which was across the patient from the patient center. And as I said, I will show you in the slides a picture of the monitor position, which meant that the practitioner had to bend over, release a catch, pull it up, and then lift this 15 kg monitor out. When this initially came in, we had consultation with our manual handling moving people instructors to come up with a solution for this initially, but it didn't negate the twisting and some of the other elements involved in the MAC2 the lifting and carrying element of it, the torso twisting, sideways bending, and postural constraints. Excuse me. And then because we generally monitor every single patient, the monitor is taken out of its cradle, brought into the house or to the area where the patient is, connected to the patient. So the lifting and carrying of that monitor is another element of the assessment, and that's where we use the carrying element, but also the ARC tool because of the amount of times that your wrist posture, arm posture, and your hand finger grip as part of the ARC tool. The next part of this, because of it, we brought a team together. So our quality safety risk manager Mary gathered a team of education ergonomists from the HSA, private ergonomists, and private consultancy, as well as other elements involved in fleet logistics within the National Ambulance Service itself. as a quality patient care, continuous improvement element to the process. With our job itself, it is very hard. We were in such dynamics, features and elements every single day. One job is not the same as the other, so there is a risk of injury, obviously. Our practitioners are trained in manual handling moving people and recertified every 2 years. The additional challenges then is the environment we work in. That is one of the additional challenges that we face on a regular basis. So environmental factors, obviously weather, dependent rain, the types of incidents we have, road traffic accidents would create oil and such like, and that can be brought into the vehicle as well. So slip, trips, falls. So we had to bring all of these elements into the factors when we were looking at the MAC and the ARC2. Picture in front of you now is a basic, that this is the Life Pack 15 without the armor or bags. It seems very light, but once you add the bags and the armor, it becomes 15 kgs. Following that, the armor protects the screen and the handle from drops from heights. And plus, it weatherproofs the device as well, because our device would be out in all weathers, potentially in rain as well. So it has to be a waterproof device. This is it with its armor on, and armor, if I can just show you, this is the armored handle and the armored cases. We reduced some of the casing to bring the weight down as well, but not efficiently enough at the time. So it still remained 15 kgs because within each pocket element of it, and we had to carry our monitoring dots, our shock pads for adults and pediatrics, plus spare paper rolls, as well as our end-tidal CO2, SpO2, ECG leads. On top of that, there is a modem in this pocket over here, connected to the device as well. The position, this is one of our Ford ambulances at the time, because there's a window in it. This is called the trauma wall, and the position from retrofit of the old MRX to this post position here, which shows you that there's a stretcher here, and the practitioner has to lean across this stretcher, pull this catch, lift up this handle, and then lift out the device using the handle and gripping at the base as securely as possible. One knee is on the stretcher at all times. The downside of that is when you have a patient on the stretcher, you can't kneel on it. So there's a twisting, bending, and postural constraints involved in remounting it. Our vehicles are all SEN compliant, so the monitor has to be put into these brackets, and they're crash rated to ensure that they don't break away during a rollover or frontal side-on crash. The bracket itself is a very basic metal bracket, as you can see, with a rubberized base to protect the base of the thing and stop rattling and noise. The handle itself, metal, with two little lugs to hold the handle itself and a button to pull, that you have to pull. So twisting, wrist, generally posture is required to do that. As all practitioners, when our service are various heights and sizes, it becomes difficult over the period of time then with different lengths and side arm length and then the height of a person. This is probably a better view of our vehicle itself. This is a Mercedes vehicle that we currently have. That's our platform now within the ambulance service. We're all Mercedes chassis with box body. You can see the reach that the person has to reach across to the Life Pack 15 and its position within the ambulance. This monitor here is an old Life Pack 12 used in some areas of the country. You can see the constraints with the practitioner standing out with a patient on it to put the monitor back on, and then leaning across the buttonology, using buttons to monitor the patient as you are treating the patient prior to moving to the hospital. One of the solutions, because we had consultation and we went through a consultation process with all the different actors within the the HSE themselves, Health and Safety Authority, Education, excuse me, and then private ergonomics as well as private consultancy involved in the group. We came together, met, we tried different things. We also got the vehicle manufacturer involved, obviously. This trauma wall is very specific, you can only mount, and there's metal frames behind that, so we only have certain positions in order to mount our heavy equipment on. It was decided then, if I just go back a slide for you to see where the suction unit is, another essential equipment in resuscitation of patients. We decided that this panel here in future builds would be moved to here, storage boxes, and then in future builds the monitor would move to this post here, and the suction unit would move to its current position. The current position then of our in our vehicle, following those design changes and retrofitting, is that we moved the suction unit to the foot of the patient, or centralized on the patient where the monitor was based, and then the monitor was used, moved to that location. The thing about this is that it negated the fact that the patient, the practitioner had to lean over the patient to get the device or retrieve the device. It also negated the twisting, bending, and reduced the lifting operations and the carrying, not generally the carrying operations, obviously, but it reduced the lifting operations by 9 points in the MAC2 assessment chart following this consultation. The other element that improved there is that there is a gap between the seat and the stretcher head that the practitioner could walk into, as in standing position, open the bracket and then take out the monitor using holding it close to the body, using the handle and the base to carry the monitor out of the vehicle, and without twisting or bending to do so. Plus, when you bring a patient into the vehicle, you can remount the LifePak 15 successfully without impeding or moving across the patient, and do so in a standing position. Excuse me. This consultation then, communication between the groups. Obviously, we sought assistance from the HSA, and Frank was involved in this element of it. In 2015, following the launch of it in the Southeast. We obviously listen to our practitioners. They're the ones who are using this on a continuous basis, and our manual handling moving people instructors, who are also practitioners, and come to solutionize the problem we had in place, which brought us to that point with the manufacturer to change the position of the LifePak 15 and the suction unit. In doing so, we created another problem, obviously, with the utilization of the suction unit. But by working with the group, the education group, as well as the ergonomic, the vehicle manufacturers, we solutionized that and came up with a solution for utilization of that and resuscitation of a patient, where you had to use suction. That was the learning of this, obviously massive learning curve in the Southeast area itself for ourselves, but this learning then was implemented and rolled out into the training pack that subsequently came when the monitor defibrillator was moved into Dublin North Leinster area of operations and the West National Armed Service West area of operations. The element of training was the moving people manual handling part of it. The position of the monitor, that was done on fit out when the old monitor and new monitor were being changed in positions. At that time, we had several different, two different types of vehicle, as I said previously, a Ford Transit chassis with a box body and the Mercedes Sprinter with a box body. Currently within the service, we now have a single platform vehicle, which is a Mercedes. and we have obviously risk assessed the vehicle during its build or prior to build when in design, identified ergonomic risks, and we then also implemented safe systems of work and practice. This is taught at our colleges with our students. It is then taught on an annual and biannual basis in the areas of operations during their annual training elements over the 12-month period. Currently, because of this training from the college student based to the practitioner on the road with over 20 years, 30 years experience in some cases, we've embedded a new practice into the service of manual handling moving people, plus moving equipment, and utilising both people to bring equipment into a patient, especially in a fraud cardiac arrest situations where you very obviously a heightened situation. You need a monitored defibrillator. You also need your resuscitation equipment to resuscitate the patient airway. And we've also, because of the equipment we've introduced on the ambulance, we also have a thing called a mechanical CPR device called the Lucas device, which is then utilised to provide chest compressions to the patient, and then again negating some risks within. So we have learned, and we keep on embedding this learning into our practice and embedding it into our safe systems of work as we progress as a service. So the new position of the monitor is easy to use because you're in a standing position. You're not bent over. You're twisting and pulling. For me, I'm a left-handed person, so I would generally have my left hand on the handle and my right hand would pull the knob. In this person is a right-handed person, so slightly more twisting and bending maybe. In this, to the fore, we have come through consultation with the manufacturers. There is a newer bracket now being fitted to our vehicles, and this is a full grip handle that will release the top mounting bracket for the LifePak 15, moving away from the bracket on the slide you see at the moment. So this is an improvement. It has taken a few years, but our company who produce LifePak 15 are American based. They've taken on board the risk assessments and the learning we have come from over here, because Ireland is one of the biggest EMS providers within the world who have totally gone LifePak 15 compared to other services where they have several different versions of monitored defibrillators in use. Taking that learning on board, they designed a new mounting bracket for ourselves, which is now introduced into the service. As I said, is a pull grip, which negates the use and twisting. So it is again further reduce this element of the arc tube. You can see that the person is now standing between the seat and the stretcher head, which makes it also easier. And then when lifting, utilizing a lifting technique close to the body, that's from taking the monitor out. The person then would move their one hand underneath the monitor and holding close to the body would exit the vehicle. To use, we don't use the handle as a single side, or we don't use the carry strap that you would see here generally anymore to carry it, because we'd unbalance, causing a twisting motion and potentially back or shoulder injuries. As I was talking initially, our current fleet is all Mercedes sprinters, and we have introduced elements and changed the design of it. In doing so, we do a clinical risk assessment as well as an operational risk assessment in doing so. And we have all currently, when we were building and designing vehicles for emergency use, we have a group of people involved, including managers at different levels to a fleet, quality, safety, risk, as well as practitioners and education involved in the process of designing a vehicle. This has brought a different mindset, obviously, and mindset change of risk management, and using a risk management approach to developing and designing vehicles, but also developing the process of looking at equipment that we bring into our service on an ongoing basis. Over the last 5 years, we've changed our clinical practice guidelines where we do now don't use final words. We have different ways of dealing with patients involved in road traffic accidents for patient comfort. We've, excuse me, we've also changed our deployment model where heavy lifts are involved. If it's emergency, we involve multiple practitioners using moving people, manual handling processes and work practices. And failing that, we would then also use the fire service to help us give lift and extricate patients from houses or cars, depending on what it is. Regionally, nationally, we have a single platform. Our vehicles are a single platform, and I did mention Dublin Fire Brigade. They were involved in this process as well because they, like ourselves, are Life Act 15. Their vehicle layouts are very similar to ourselves, and they are involved in our learning how we have developed our vehicles from that. Our staff are involved, as I said already, in the process, and our staff are trained on a regular basis in moving people, manual handling, and any new and evolution parts of equipment that we bring in. There's a training exercise, generally a day, but incorporating existing practices into that day as well, which reinforces and helps the practitioner bring scenarios where they'll use the equipment and the functional parts of the equipment into their environment in different scenario settings. One of the biggest elements of ourselves that we have in the service learned over this period of time is the power of involvement. And not only involvement of ourselves, but the involvement of external bodies and external people. Because I suppose as a practitioner myself, we are kind of blinkered to a certain degree of what we do and how we do things. By bringing the likes of Frank in at that element and other colleagues from the HSA, HSE, Health and Safety, as well as independent consultants and ergonomics, we have taken the blinkers off and looked at the way we design and do things differently by using the MAC tool, by using the ARC tool on a regular basis when we were looking at equipment, but also designing vehicles and negating the twisting, bending, rotation movements that we would normally have done on regularly prior to this on older vehicles. We now try to fit the vehicle to the person rather than the person to the vehicle, which is our way of looking at stuff now. And for us, that's like it's joining the dots in every element of what we do and how we do things. So we have a consultation process where health and safety, occupational health and safety elements, as well as manual handling, moving people, instructors, the education element, ECAT of our organisation, as well as the ECAT from Dublin Fire Brigade, are involved in moving forward, looking at equipment in a different way, and then implementing this through our regulator, Pre-Hospital Emergency Care Council, in developing new clinical practice guidelines for our practitioners with safe work practices involved in that. Once we try and utilize this, we obviously trial these for a period of time. We do the work, and then if they work or any changes need to be done, we will change them going forward. The biggest element of this going forward for ourselves is the practitioner involvement. Currently, we have in the service nearly 2,000 personnel with 1,600 practitioners at different grades and different levels of experience. So, any questions?
Thank you, Anthony. We'll do the question and answer session at the end, but that was a really, really interesting presentation. Thank you very much for that. And it's interesting, a couple of very interesting points around mindset change and continuous improvement. The fact that we can't just stand still. That when I say we, I mean we in the HSC and everybody else. We have to be conscious that things are changing, evolving all the time, and we have to look at new ways of managing risk. But the mindset thing is key, I think. And I think in terms of workplace management, in terms of risk management, I think mindset is a big thing, particularly around looking at health risks into the future and how we deal with those. from a very early stage of design right through to the kind of case study that you've just presented, which has been very interesting. So thank you for that.
Thank you.
Before I introduce Ita, I just want to mention two things. Ita will have a break halfway through our presentation for 2 or 3 minutes, just to kind of comfort break, to just get up and move about. And the other thing is just to remind you that don't be afraid to answer or to put in some questions into the Q&A, which we will cover at the end of today's presentation. So without further ado, I'd like maybe just to give a brief introduction, shall we say, to Ita. Ita has been working with us on these webinars and workshops for the last 5 years, and it has been a very constructive process, which is we're delighted to be involved with Ita on this. She's Managing Director of Leyden Consulting Engineering based in Waterford. Ita is a chartered engineer, ergonomist, and a chartered member of the professional body for health and safety, IOSH. She's also a forensic engineer. She has over 25 years experience working in the medical device industry and other industries, and she does a lot of work in the not just health and safety but in the engineering professions as well. So Ita is going to present on the Mac tool now and the practical elements, which are all I'm sure very interested in. So I'll hand over to you, Ita. Thank you very much.
Thank you, Frank. Sorry, just turning off my heater there so I don't overheat during the presentation. Delighted to have the opportunity to talk you through this workshop today. If you haven't at this stage downloaded the guidance to the Mac tool, I'm going to encourage you to do so, because during this workshop, you're going to get the opportunity to try out the Mac tool in real time. So in terms of what I'm going to cover in this workshop, we're going to talk you through very briefly the suite of tools that have been developed by the Health and Safety Executive and endorsed, as Frank said, by the Health and Safety Authority here in Ireland. And then we're going to look at completing a MAC assessment and looking at how they are done and what guides you need to follow using the guidance documents from the HSE, which you can access via the HSA's website. Actually, I'm going to start using page down here. So again, as Frank mentioned, and Anthony referred to as well, that musculoskeletal disorders are a very common occupational ill health, and an awful lot can be done to prevent them. But very pertinent to that is to identify which area we need to focus our attention on when we are introducing improvements from a musculoskeletal health perspective. And the early reporting and identification of issues is critical in relation to improving musculoskeletal health in our workplaces. And to assist us with that, as we all know, in terms of risk assessment is about trying to identify what can go wrong before it does and implementing remedial or corrective actions to prevent something going wrong in the future. So to do that in relation to musculoskeletal ill health, we have 3 guidance or documents that comprise the HSEs, and HSE referring to there as the Health and Safety Executive in the UK. I'm conscious that many in our audience today are from the Health and Safety Executive, sorry, the HSE in Ireland. So we have 3 guidance documents from the UK, and the first one is MAC, and MAC stands for Manual Assessment Charts, and that's the one we're going to focus on in this workshop. We then have the RAP tool, and RAP tool stands for Risk Assessment of Pushing and Pulling Tasks. And then we have the ART tool, and ART stands for Assessment of Repetitive Tasks. So as the name suggests, the MAC is aimed at general manual handling activities. The RAP is aimed at activities that will involve pushing and pulling. And ART is the tool that should be used for repetitive actions or movements for the upper limbs. And as Frank would have mentioned, you have worked examples of these as well in the recent HSA publication, Risk Assessment for Managing Ergonomic Risks, which again, there's links to and you can download. So what the MAC tool helps us to do is to identify the most common risk factors associated with manual handling activities. And what you'll notice is that in the workbook, there are 3 different guides to assessing manual handling activities. MAC allows us to assess lifting, and when we're using assessing a lifting activity, we use the lifting guide. When we're assessing a carrying activity, we use the carrying guide. And when we assess a team handling activity, we assess or we use the team handling guide. And I'm going to explain those to you as we go through the workshop this morning. Importantly, the MAC tool is not suitable for some manual handling operations. So for example, if it's a pushing and pulling operation, well then the wrap tool is more suitable. And it's not suitable for activities involving repetitions of the upper limbs, and that's when you use the ART tool. And I should also mention here, particularly for our audience today, that the MAC tool isn't sufficient on its own in relation to the assessment of patient handling. However, from the healthcare sector, Frank gave you lots of examples where manual handling is carried out as an integral part of day-to-day activities in the healthcare sector that exclude patient handling, whether it's handling equipment, linen, maintenance, beds, etc. So just in terms of the MAC tool, you'll have had the, this is the PDF version of the MAC tool that you can, you have the link to do a free download. However, you can also, if you so desire and have a little bit of extra cash, you can purchase the lovely pre-printed publications as well in A5. I'm very practical, however, I much prefer to use the free PDF version, and that's the version that we're going to be looking at today. And what you'll see in the MAC tool, in that PDF version, that when you open the front page, as you go to the second or the third page, in fact, you'll see that there's a different color banner across each of the guides. So here we have a blue banner across the top, and the blue banner, all the pages with the blue banner across the top are the guide for a lifting operation. Then further into your document, you'll see a red banner across the top, and the red banner indicates that that's the guide you're using for a carrying operation. And then further down, you will have a green or a tealy color across the top, and that's the guide that you'll use if you're assessing a team handling operation. And of course, most importantly, we have to first identify whether or not a manual handling assessment is required. So you have, as part of the tool as well, a check sheet to identify, do you need a full or more detailed risk assessment than using your MAC tool? And where you'll find that is on page, and I'm just trying to locate the page here at in my document. I should have had it open, of course, and it's on the score sheet of your MAC tool. And it's on page 19 of 20. I've actually already taken it out to show you. So page 19 of 20, you will have the score sheet, and on the left-hand side of the score sheet is where you fill in the details of the activity that you're assessing, and on the right-hand side of the score sheet, it gives you a tick box to ask questions whether or not a more detailed assessment than MAC is required. And they include things like activities that involve lifting or lowering more than 12 repetitions per minute. And again, if that's the case, MAC may not be the ideal tool to use, but you might use MAC as part of your overall more detailed risk assessment. If it involves manual handling activities in a seated position, where your males are carrying more than 5 kgs or handling more than 5 kgs, or females more than 3 kgs, again, MAC may not be the tool for you. And also what you'll see here, that if there's individuals who may be present a particular risk because of their predisposition due to, or indeed due to pregnancy, then MAC may not be the full assessment tool that you need. What you will reference here, however, is there is reference to the manual handling operations regulations. So this is a tool that was developed in the UK. So some of the references in the documentation refer to UK legislation. However, that really doesn't make any difference in the overall scheme of things. Both the legislation in the UK, for the moment anyway, and in Ireland have their basis in Europe anyway. So the requirements aren't very, very different. One of the other things that we need to capture, if it's obvious to us when we're doing an assessment, is any psychosocial factors that could affect musculoskeletal health. And they include things like high workloads and tight deadlines or lack of control over the working methods. A little word of caution here. This isn't something that if you observe and you believe this to be the case, that there's a psychosocial factor present, that we document it. It's an area where if it's brought to your attention by those that are doing the assessment, that there may be other factors, that's when you document those, and then you can pass them over to the relevant competent individuals to assess the impact of those in the workplace. So how do we do a MAC assessment? So the first thing we're going to do is you look at what task are you going to assess, and based on that you'll identify whether or not you are going to use the lifting guide, the carrying guide, or the team handling guide. It's very important that when you're doing any of these assessments that you do consult with those carrying out the activity, and always engage. It's not something that should be done in a covert basis. So then you complete the page 1 of the score sheet, which includes, as I say, the company and site details, or indeed, as you'll see here, are there any indications that the task is a high risk for musculoskeletal disorders? And the task might be something that might indicate the task is a high risk is if there has been a history of manual handling related incidents or accidents involving the particular activity or task. And here you'll see again a reference to the UK's version of our legislation, which is RIDOR, and RIDOR stands for the Reporting of Injuries, Diseases and Dangerous Occurrences. That's the UK's version of our reportable accidents. So obviously, if you've had a reportable accident, and again, just to remind you, an accident is reportable in Ireland if it results in someone being out of work or not able to carry out normal duties for more than 3 consecutive shifts. It's reportable to the HSA. And if you have had manual handling related accidents that result in that, well, then that would give you an indication that, listen, this is a high enough risk activity that should justify an assessment sooner rather than later. So how do we actually physically do the assessment? The most important thing for any assessment is observe. It's look and get an understanding of the activity and what's going on. Now, this may be carried out on the hoof or in person, and the MAC assessment can be completed in person. However, depending on how complicated the task is, it may help to video the activity. Now, what I should say here is I'm not saying that someone sends you a video and you do the assessment. As we'll see during the exercise in a few moments, if you've not been in a workplace and seen the activity, you're not really going to be able to do a comprehensive assessment. You need to be able to see the condition of the floor. You need to be able to see or feel the temperatures and observe closely what's going on. So when I'm saying videoing, I'm talking about you capturing the activity on video. Of course, always usual word of caution on that one is be aware of your GDPR requirements, get permission, and only use the video for the purpose for which it has been taken. Then we can select the appropriate type of assessment. So you select whether or not you're going to do, does this involve a lift, or indeed a lift and a lowering are the same type of assessment? Is it a carrying or is it a team handling operation? And indeed, some assessments might involve that you're assessing the first part of the activity is a lift. The next part of the activity might be a carry. Someone lifts a container and carries it a certain distance and then lowers it onto a table, for example. So that might involve 3 different assessments. So it's very important that when you're doing these assessments that you're familiar with the guide, and that the more familiar you are with the documentation, the quicker the assessment will become for you. So once you're following the assessment guide, which we will go through, it's the same for all of the HSE's suite of tools, whether you're doing a MAC, an ART, or RevRap. There's always a color associated with the risk and a number associated with the risk. And in relation to the MAC, we have 4 color codes. We've green, as Frank mentioned, low risk, amber, medium, or red for high. But we also have this purple risk. And a purple risk is really where the risk potential is, or potential for injury is off the Richter scale. Then what we do is we look at each individual risk factor. We assign a color and a score to each individual risk factor. And thereafter, we work through a process flow and we complete a sample score sheet. So the score sheet as well, so you'll see that is on page 20 of that PDF, the link that you would have had there. And on the score sheet, you have each individual risk factor in the first column. And then across the top row, you'll see that there's a title for a color band and a numerical score. So for example, when we follow the guide and we're assessing the risk factor of load, weight and frequency, which we will be doing in a moment, we will assign a color. So if the lift falls into a weight that's carried out in a particular frequency, our guide will tell us what color that risk is and will also give us a score for that risk. So what we'll be doing is in the first column, we will, for the lift operation, across from the load, weight, frequency, we'll be putting in a color. Now, here, if you're using a manual system, you can go use all fancy, get all fancy with your colors and use your green, red, and amber and purple marker. But when in a paper system, you can also just write in the letter G for green, A for amber, R for red, P for purple, which works as well as effectively. And if you're using a cloud-based system or an online system such as Easy Ergo, then this will pre-populate in the colors for you once you make your selection. And then in the fourth column there, you'll see under numerical score, you have lift as well, and your guide will tell you what score you should put in there. So for each risk factor, you're going to have a color and a score. Now, one of the things that we're familiar with normally when we do risk assessment is that we end up with an overall score, and that overall score then gives us an indication of the level of risk. MAC is different in that respect, because with MAC, although there is a total score calculated, that total score on its own doesn't mean anything in relation to risk. Each individual risk factor on its own could cause a musculoskeletal injury. And therefore, when we're doing a MAC assessment, we look at each individual risk factor independently. And if we have a red or a purple risk associated with load, weight, frequency, or the vertical distance that someone is lifting, we highlight that, and that's the risk factor that we need to focus on. So why you might ask, is there a total score on the score sheet? This is just to help us to prioritize which tasks we need to focus our attention on. So obviously the highest score here is the 17, which is the carry task. So in this particular example that you're seeing on your screens at the moment, we'd focus on the carrying activity first off, and then within carrying, we're going to focus on the red risks and purple risks first, red risks then, and then we look at the red risks with the highest score. And that helps us to focus our mind as to where we need to make improvements. So I'm going to ask you to go to the flow chart for lifting operations. And the flow chart for lifting operations, as I'm finding it here, is on page 7 of your downloads or your printouts. And as you'll see, the flow chart just requires you to assess each of the risk factors associated with lifting. So they include load, weight, frequency, hand distance from lower back, vertical lift zones, torso twisting, and we follow it around postural constraints, grip, etc. And in your guide, there's a guide as to how to assess each of those risk factors. So we're going to first look at the load, weight, frequency. So your guide for assessing load, weight, frequency is on page 3. And this is the guide for load, weight, frequency. And how you use this one is to assign your color and your score is you find out what weight a load somebody is lifting. And you also find out how often that lift is carried out. So if someone, for example, is lifting a 30 kilogram load and they are lifting that load once every 2 minutes, what we do is we find the load on the x-axis. So I always get my x's and y's mixed up, so apologies about that one. If it's 35 kilogram loads, on the kilogram axis there, we find 35. And then we go across and we meet the line coming up from once every 2 minutes. So from the one lift every axis, we come across, and you'll see there a 35 kilogram lift once every 2 minutes is just inside R6. So that gives me a NOR in the column for load lift frequency and a 6 in the column for score. And we then look and we assess the hand distance from the lower back. So each individual risk factor is what you look at. So based on your pictograms, you look at where is the load being lifted, and based on where the upper arm is aligned with the torso, that'll tell you whether or not the score is a green 0, an amber 3, or a red 6. And then we look at the vertical lift zones. And what you'll see here is you're looking at whether or not the lift is being held between knee and elbow height, in which case that's green. Now, if for example, someone is lifting a 30 kilogram load between knee and elbow height, we don't say, oh, well, it's 30 kilograms, because we've already assessed the load weight in the first risk factor. So once we've assessed the load weight, we don't take account of that again. Now we're just looking at the vertical lift. And previously in B, we just looked at the hand distance from the lower back. So if the hands are between knee and floor level, or hand and head height, well, then it's an amber 1. And then if it's at floor level or below or above head height, then it's a red 3. And what you will notice here is for this risk factor for C, red is a score of a 3. And our previous one, red had a score of 6. And our previous one, red also had a score of 6. So the red risk in itself is weighted based on the how much it can impact the potential for musculoskeletal disorder or musculoskeletal ill health. We then look at whether or not the body is twisted or sideways bending. If there's little or no, it's a green 0. If it's twisted or bent, the upper torso, it's an amber 1. And if it's twisted and bent, it's a red 2. Then we look at any postural constraints. So here we're looking at, does the person carrying out the lift have to restrict their posture somewhat because of what's around them. So for example, going through a narrow gap or a narrow doorway, or having to duck their head through a narrow doorway, or under machinery or under pipe work. And again, that's an opinion as to whether or not the person has restricted posture or severely restricted posture. Then we look at grip. So again, here we're looking, the pictograms are very good and they're in your guide. And if there's fit for purpose handles, it's a green. If it's your hand holds or your standard pommel grip, it's an amber 1. And if it's a poor grip, as you'll see with the bag or the sack, it's a red 2. Then we look at the floor surface. So again, this can contribute to the potential for musculoskeletal ill health. So we look at the floor in good condition, reasonably good condition, or very poor condition. Then we also look at environmental factors. So we look at, for example, are there extremes of temperature, or are there somebody working in an area where there's significant gusts of wind that could result in musculoskeletal ill health, and we score accordingly. And I beg your pardon, I think I've skipped 1, but what we do is we're going to give you a chance to try this out now. So what I'm going to ask you to do is to go to page 20 of your printout or your PDF. And when you come back from a leg stretch, I'm going to show you a video, and I'm going to ask you to try and score that by following the blue guide in your workbook. So you're going to start at page 3. So please have page 3 and page 20 ready to rock and roll when we come back from, it's literally a 3-minute leg stretch. We have certainly less than an hour to go. So if you wouldn't mind, we're going to be back here 12, 13, just hit 12, 11, 12, 14, we're going to kick back off again. So see you in about 3 minutes, everyone. Thank you. So Hugh, I might ask you just to get the video ready to rock and roll there, please. That would be great. And you're all very welcome back. Some are saying there they have to receive the link. The link was on the further up in the chat box. So when you logged in, if you go to the chat box, there's a link there to the PDF. So what you're going to see now with this video is an activity that involves an individual lifting boxes. So I'm going to ask you to go to the correct lifting guide, or sorry, the correct guidance. In this case, it's going to be the lifting guide. So we're going to use the blue, the first third or the first section of the Mac tool, which is the Lifting Operations Assessment Guide. And what we're going to do is we're going to see or observe this for 3 goes. And that's very important that you don't jump in and start to, oh, I'm doing the assessment now, because you need to see it. He's unloading a pallet, so you need to see it from the beginning all the way through. So you can play away there, Hugh. That'd be brilliant. Thank you. So we're going to see it, and then you'll get information about how frequently the lift has been carried out and the weight. So in practice, you'd stand and you'd look and say, right, which of the guides am I using? Is it a lifting? Is it a carrying? Or is it a team handling operation? So in this case, it's quite obvious it's a lifting. And as you'll see, as will normally be the case, lift any task isn't the same every time. So here he starts with the pallet full and he's going to the bottom of the pallet. So which element of that do you assess? You assess the worst case scenario. So obviously when he's taking the boxes from the middle layer, his posture isn't quite as bad as it is when he's taking the lower box. So that's the worst case scenario. So that's the one really that we're going to be scoring. And we'll see this a couple of times now. And so you've obviously identified at this stage that it's a 25 kilogram box, and that's written on the outside of the box. And in a few moments, we'll see the frequency coming up. Now, one of the things that's quite common when we're doing assessments is that you won't have the weight written nicely on the outside of a uniform box. So quite often I will have to bring pieces of equipment to scales or otherwise, or try and get an estimate of the weight. So here we go again. So we have one lift every 9 to 14 seconds. And it's 25 kilogram load. So what I'd like you to do now is to go to page 3 of 20 and write in your score sheet, opposite load weight frequency for a lift, what color does that fall under and what score. Now I'd like you to go to look at the hand distance from the lower back and look at where his arms are relative to his upper torso and give a score and a color code for that. Now you're going to look at the vertical lift zone. So you're going to see or score it based on the fact, is he lifting between knee and elbow height? Is it between knee and floor level? Or is it on the floor or below? And based on that, you put in your color and your score. Now we look at the torso twisting and sideways bending. So put your score in for that. Now this is very much a whistle stop workshop, so you'll forgive the pressure for you to just assign a score. And are there any postural constraints there that he has to maneuver around in relation to that? So give that a score and a color as well. Now you're looking at grip on the load. What's his grip? Now this is where we come into difficulty. What's a floor surface? You can't see that, so that's why you do need to be present when you're doing your assessments. And any environmental factors that you might think might be present there, again, to do those, assess them properly, you need to be in the location. So Hugh, I'm going to ask you to go back now, if you wouldn't mind, to my presentation, and we're going to allow people to compare their, albeit very quickly scored, assessment with the scores given by the health and safety executive experts. So, load weight frequency, red 6. So we had our 25 kilograms. We bring it across for 1 every 9 to 14 seconds, and that immediately falls into red 6. Hand distance from the lower back, yes, it's red 6. You can see that the upper arm is well extended away from the torso. Now the vertical lift zones, it's amber 1. Now many people would have scored this as a red, and an amber is if it's between floor and knee height. So it's on a pallet, so therefore it's not actually on the floor, it's on a pallet. That's why we get an amber 1 there. There is trunk twisting and sideways bending, so we have a red 2. The postural constraints there are obviously the conveyor is causing him to restrict his posture. Grip on the load is your amber 1. Again, floor surface, can't see because we're not there. So you really need to be present to do a comprehensive assessment. And again, you don't know if there's any environmental factors. So I'm going to tell you that there aren't any excessive temperatures or otherwise. So hopefully you scored fairly okay on that one, but it's very important that you get practice in on this and get more training if necessary on using the tools. But there are also worked examples in the HSA's publication and other videos that you can try out on the HSE's website, which there's a link to from the HSA guidance. So now we're going to go to look at another short video. And in this case, it's a carrying operation. So we're now going to get you to look at the assessment guide for carrying. And they all have the same touch and feel, which is great with all the HSE tools. And this is on page 12 of 20. So if you go to page 12, and here with the carrying operations, again, similarly, we're looking at load weight frequency, hand distance from the lower back. But we have a different one here. We're going to look at the asymmetrical torso or load. And there's a guide for each one. So the assessment guide for the carrying operations, it's quite similar. However, be very much aware that it is slightly different. The scores are different. So it's very important when you're doing your assessment that you are following the right guide. So it's the same principle. You get the weight and the frequency, and based on that, you get your score and your color. But of course, on your score sheet now, we're going to be filling in the carrying column. So the carrying column under color band and the carrying column under numerical score. The hand distance from the lower back is the same again. So again, you're looking at the same graphics here and the same scoring. Now, however, we're looking at the asymmetrical torso or load. We don't have a vertical vertical lift because we're carrying, so it's already up. So now we're looking at how we carrying the object or the weight or load relevant to our torso. So if it's in front of our torso, it's a green 0. If it's to the side, it's an amber 1. And if it's a two-handed operation to the side, it's a red 2. Again, we look at our postural constraints. And hopefully you're seeing as we're going through this, I'm going through the guide, and we're now on page 9, looking at the risk factor D. We now go to page 10 and we're looking at the grip on the load. Again, the same pictograms as we would have had for the lifting, same scoring. And floor surface, again, same criteria for scoring and rating the floor surface. However, now we have to include the carry distance. And here we're talking about a carry distance without an opportunity for a break along this distance. So if someone's carrying something between 2 and 4 meters, it's green, 4 and 10, it's 1 and amber, and it's over 10, red 2. Now, one of the beautiful things about these tools is that you're not expected to start taking out protractors and measuring angles, or you're not expected to take out measuring tapes and measure physical distances. Stepping that out is more than acceptable, or estimating whether it's between 4 and 10. So if you're anal about it and start measuring, and that's actually 10.1 meters. One, you're going into too much detail. So if it's in around the 10, that's fine. If you're looking at approximately 11, 12, but then you're talking about over 10 meters, it's a red 2. Now we have another factor that we're considering, because when you're carrying, you have to consider, do I have to work around any obstacles? And the obstacles are things that I have to step over, etc. And what we're looking at here, we're looking at either carrying up and down a steep slope, up and down steps, through closed doorways, around tripping hazards, or up ladders. And what we're looking at here is the number of different types of obstacles, as opposed to we're talking about types of obstacles as opposed to the number of obstacles here. So if I have to step over a cable and then I have to go up a slope, that's amber 2. Then we look at the environmental factors, same thing again. We're looking at there the strong winds, temperatures, etc. And that again will give us an overall score, but we're not concerned about that in terms of the overall level of risk. So it's your turn again. So now we're going to, if you wouldn't mind, I'm going to ask you to please set up the next video for me. And the next video is a carrying operation. So it's our same willing volunteer now is going to be taking the boxes from the conveyor and bringing them to another location. So again, with the carrying operation, whether it's in person or otherwise, you observe, observe, observe. So we're still following the red guide, and what you're going to see on the video is, again, you can play away there, Hugh, please, that would be brilliant. And again, you'll see it's a 25 kilogram load. And we'll observe it a couple of times before we get the frequency there so that we can rate the load weight frequency. Okay, so we're observing here. And at this point, what I'd like you to look at is that, yes, he has to duck under pipe work. And yes, he has to walk around things on the floor. So we need to consider, is the pipe work an obstacle or does it affect posture? And in this particular case, what we'd be saying is it's the pipe work that gets him to adjust his posture. So we're going to capture that under the risk factor of postural constraints. And then the items or the obstacles en route are those that he has to walk around. And we're looking at the different types there. How many different types of obstacles does he have to walk around? We capture that under the obstacles risk factor. So now we get some more data. So it's 25 kilograms every 20 seconds this time. So every 20 seconds, he has to carry a 25 kilogram load. So I'd like you to go and score this now on page 8 of your printout or PDF and identify the weight and then go along and match that with the frequency and get your score and your code. I'm now going to ask you to look at his hand distance from the lower back when he's doing the carrying. And score that based on color and hit score again. And now I'm going to ask you as to whether or not how he's carrying the load. Is it asymmetrical to his body? Is it in front of his body? And score that. And remember, you're scoring these now under the carry column under color and score. Are there any postural constraints? Now, again, here we're looking at something that forces the worker to modify their posture. I think I've given it away there earlier on by talking about the overhead pipe work. Then we're going to look at the grip again. Score the grip on the load. Floor surface. Again, you can kind of see the floor there, but you wouldn't know if there's any spillages or torn carpets that he has to in the area that you can't see. So we're going to say in this case that the floor surface is in good condition. Then we're going to look at the carry distance, estimate that. Now we're going to look at the obstacles en route. How many different types of obstacles does he have to walk around? And do you think there are any environmental factors? Okay. Again, a whistle stop. You can stop it there now for me, Hugh. Thank you very much. If you wouldn't mind going back to the presentation. And it was very much a whistle stop. And I've just realized that as this is our fourth, or I think our third one in the series of webinars, I am speeding up and I don't intend to. My familiarity is increasing my speed of going through these. But so let's look and see how you scored, and we'll have a little chat and talk through the scoring. So firstly, our 25 kilogram box once every 20 seconds, that was an amber 4. So A for amber and 4 there. The hand distance from the lower back was green 0. Now, I would imagine that many of you today have scored that as an amber or higher. And the reason that it's a green 0 is that although the arm is, and I'm going to actually just tilt this down a second so you can see me. The arm is out to the side when he's carrying the box, but we're capturing that element under the risk factor for asymmetrical trunk load. Even when he's carrying something out to the side, his upper arm is still in line with his torso. So even though he's holding it out to the side, his upper arm is still in line with the torso, so his hand distance from the lower back is still close to his upper torso. It's not like that. So that's why that is a green 0. Then we're looking at our postural constraints, and yes, he has to duck underneath the pipework, so it's an amber 1. Then we're looking at the grip on the load. So again, that's your standard pommel grip, amber 1. And again, many have concerns about the fact that the training that we give people during manual handling training is that pommel grip. So we're actually training people to have a low scoring amber or medium risk. And the reason for that is there are better ways of holding our gripping loads, and that is if there are specific handholds or handles, I should say, on a load. The next one we look at is, as I mentioned, floor surface, green 0, no problems. And again, here what I'd like to highlight is that the guidance asks us is if the floor is in good condition or bad condition, and it is a subjective opinion. But all risk assessment really is, there's a little bit of subjectivity to it. The most important thing is that we're all applying the same principles in any one organization. And I think that's what's lovely about this tool, is that the graphics help us to consistently apply the same thinking in relation to each risk factor. But where there's an absence of graphics, such as in the case of floor surface, then there is always that little bit of subjectivity. Carry distance, we're reckoning between 4 and 10 meters. So amber 1 here. And obstacles en route, there are some trip hazards on the floor in the corridor, and there's 2 different types. There's the boxes, and then there's the container or the silver pipe covering. So that's where we have an amber 2 there. And it doesn't appear from the video anyway that there's any other environmental factors. But of course, as I say, in a real workplace, you would be in person, or the assessor would be in person looking at the particular area. Now, in terms of, we're not going to do an example of this, but I want you just to look at the assessment guide for team handling. So this is the teal or the green part of your printout. And this team handling guide is on page 17, which is where you're going to get your process flow. And then your guidance for each one starts on page 13. So the first thing we're going to look at in terms of a team handling operation is the weight that's being carried and how many people are carrying that weight. We're then going to look at hand distance from the lower back all the way through, following that process flow. So the load weight, here we look at how many people are involved and what weight are they carrying. So if, for example, you have a 140 kg weight and it's going to be carried by 3 people, do a little exercise there in your heads as to what score you would put that. So 3 people, 140 kg weight. And hopefully you've all identified that's a P10. It's off the Richter scale, really not an acceptable lift in any organization. We then look at the hand distance from the lower back. And importantly here, for a team handling operation, we're looking at the worst case scenario. So if you have 2 or 3 people carrying out a handling a load, and one has their arms well away from their body and the other has their arm in line with their body, you score it on the basis of the person with the arms away from their body. Similarly with vertical lift zones, from a floor level perspective, everyone is going to be the same, you know, whether it's at floor level or below. However, when it gets to the upper level or the upper side of things, it can be different depending on the stature or height of the individuals involved. So if you have someone who's of a smaller stature doing a team handling operation with someone of a higher stature, one could have it be handling the load above their head, and another could be handling the load at their shoulder. So again, here you're looking and you're rating the worst case scenario. Similarly with torso twisting and sideways bending, you're looking at all of those involved in the lift or the handling, I should say, and you're scoring the worst case. Postural constraints, again, you're looking at, does any of the team members have to modify their posture during the handling operation, or do all team members have to modify their posture during the handling operation? Grip on the load, again, here it's your standard, and again, you're now starting to see get familiar with the pictograms and what we're trying to observe during an assessment. Floor surface, same thing. And the carry distance, again, you're looking at for how long or what distance a team have to handle a particular load. And similarly, are there any obstacles en route? And if you have 2 people doing a handling operation and one has a straight run and the other has to step over stuff, well, then you're assessing the person who has to step over the stuff, and you're including that in your assessment. Now, very importantly for a team handling operation, we're going to include the risk factor of communication, because if during a team handling, communication is poor, as in there's no one in control, there's one person starts to lift before the other, one person goes one direction, another person goes the other direction, that of course isn't going to contribute to the potential for musculoskeletal injury. So much so, it's actually a red and it's rated 3 versus, you'll see up here where we got a red, we have a red 2. So a red 2 is for torso twisting, that's weighted as less of a risk factor than poor communication. So beg your pardon, I'm flicking through these again. So again, is it planned? Communication is part of the team lift, and also then we look at the environmental factors. So what do we need to consider? As what's a whistle stop? So one, does the manual handling task need assessment in the first place? And here we would normally look at the standard guidance, and you may have seen from the Health and Safety Authority, your standard, you have the individual and you have a 25 kilogram load, 5 and 10 close to them. That gives you an indication as to whether or not a manual handling assessment is required. Does it require a full risk assessment, as in is there somebody with a particular predisposition, or indeed is it patient handling, or is it an activity that's not specifically covered by the MAC tool? Is the MAC suitable? Then if it is it a lift, is it a carry, is it a team lift, or maybe it's a lift, a carry, and a put down. So therefore you have 3 assessments. And there is a VMAC, and a VMAC is for varied manual activities, and this is available as well, and this allows you to give an indication of risk for somebody who's doing repeated lifts of different weights throughout their shift. So very, very applicable. I'm not too sure where it might apply within the context of the healthcare, but very applicable to someone working in warehouse or stores or distribution centres. But most importantly, the purpose of any assessment is to identify and reduce the overall levels of risk. And what MAC allows us to do, and RAP and ART is to allow us to identify where we need to focus. Do we need to focus on the weight? Do we need to focus on the frequency? Do we need to focus on the fact that the person is carrying, or the weight, the load has to be lifted with the arms away from the torso? So it allows us to, as I say, focus on which risk factor is contributing most to a potential musculoskeletal disorder or musculoskeletal health, and then helps us to identify what corrective action we should put in place. There's the paper exercise, or the paper version that you have there that you've been working on today. There is a couple of alternatives out there. The one obviously that I'm going to be talking about, I reference and recommend, is a tool called Easy Ergo. And I was involved with the development of that tool, which is an online cloud-based system that allows you to carry out these assessments. You have all the graphics, you've dropped down tick boxes, and it will help you to complete a MAC, an ART, or a RAP assessment in less than 20% of the time it would do on a paper system. And then you also have your cloud-based record, searchable record, etc. And it also addresses, which we're not talking about today, the area of DSEs and VDUs. So if you'd like any more information on that, please feel free to contact me at ita@lce.ie. I think I'm going to hand back to Frank, as we're going to go to our questions and answers. So thank you all very much.
Ita, thank you very much for that. That was a very comprehensive overview of the tools. And we do appreciate that it's challenging to do all this on a webinar, but I think the main objective is really to create an awareness of what the tools are.
Exactly.
How they can be used, and most importantly, to give a practical illustration of how they can be applied in workplace settings. And I think that's the main thing. And we've given the links to where people can get the information, and on everything from Easy Ergo to Mac Tool and RAP Tool, and our own website as well. And I think it's important to keep in context as well the importance of collecting good quality information, because there's no point in using the tools unless you have the proper information to input to the risk assessment tools. So thank you for that, Ita. Anthony, I'll ask you to put on your camera now, please. We'll just do a question and answer session now for a few minutes before we wrap up. So maybe I'll hand over to you, Barry, for a couple of minutes. We'll get a few questions in before we finish up. So Barry, I'll hand over to you. Thanks.
Thanks very much, Frank. The very first question I have is for Anthony, and it comes in from Angela. And what Angela wants to know is, she wants to know how long it takes from the identification of the issues of the improvement plan implementation. She's just trying to understand the guideline, the timelines you had on that.
Okay, with regard to our timelines, at the time we had some clinical issues as well with the LifePack 15 rollout. So for a 2-week period, we'd stopped the rollout, and that 2-week period with that element was also identified. So it gave us kind of 2 weeks grace. I think, I could correct on this, between 3 and 6 months before everything was put in place and a final decision was made on where the rollout was put, and where the monitored defibrillator was, and what safe work practice we want to put in place with that. So it sounds very a short time frame, but you have to take into account that it was a national rollout. We were the first crowd to have this rollout in our area of operations, the Southeast, before moving into other areas of operations. So the whole educational piece, fit out rollout, were encompassed. So it was a big project. So a lot of actors were involved in this. So and that's why things were done on a rapid basis to get it done. So between 3 and 6 months. Plus there was a time frame that would stop the rollout because of some clinical issues, and we're working through those as well, which gave other people time to have a look at vehicles, how to best move things around. And the easiest solution for ourselves was, because of our trauma wall and the reinforcement of our trauma wall in the build, it's the only place where you can mount objects like that. And the easiest option available from the manufacturer's point of view, from ourselves, from fit out with our service provider, was to move the suction unit change position with the monitor defibrillator.
That's great, and thanks for that. Ita, the next question I have is for you. It's just from Margaret. She wanted to know what the score was for the torso twisting. She thinks she may have skipped over it.
Janie Mackers. The torso twisting would have been, just bear with me now, on both of them. That's not the team lift. For the carrying, no, on the carrying, there's no torso twisting. It's based on the asymmetrical load. So, and maybe that was the score you were talking about there. And then for the lifting operation, the torso twisting was read 2. So there isn't actually a torso twisting risk factor with the carrying operation, because your twisting is depending on where you're carrying the load. So we capture that as in relation to whether or not it's asymmetrical to the body or not. Hopefully that answers your question. I'm just seeing there if I got it. It is the C, asymmetrical torso or load, page 9 of 20. Okay, hopefully that answers your question.
That's great. He'd appreciate that. Frank, I think the next two are for you. It's from Navid. He wants to know, do you have a case study of behavior-based study on healthcare workers due to the increased workload in the administration sector? And he also wants to know about the inspections of private hospitals due to the risk of exposure in these departments, which was discussed in the webinar.
Yeah, thank you very much for those questions. And with respect to the behavior-based case studies specific to administration, we don't have a specific one that looks at that. However, we do have a lot of very useful information on our website around behavior-based safety and guidance with respect to that. But if you look at this case study today, I mean, it gives a very, very good illustration of, you know, how behavior in terms of the work practices can be seriously impacted by the design of the workplace and the environmental factors in the workplace. So I think it's important to keep in mind that when we do look at behavior-based safety, that we don't make assumptions that everything is all right or okay with respect to the physical work environment. But I would urge you to look at our guidance. We have a lot of very useful guidance on the website with respect to behavior-based safety. With respect to the second question, our inspection regime is very much risk-based. However, in relation to the healthcare sector, we carry out inspections in all areas of healthcare, whether it's private or public, whether it's nursing home or hospital, whether it's community care centres. We do a range of inspections in all those areas within the healthcare sector. So hope that answers the questions. Thanks, Barry.
Thanks, Frank. I've got another question here, and it's about the environmental assessment. The indication of it, is it relevant, and what is defined as extreme?
So I suppose there what we're looking at in terms of the environmental side of things is if somebody is working outside and it is there's a gentle breeze, not an issue. However, if there are strong winds and someone is carrying something, if there's a potential for the wind to catch the object, that could result in a reaction by the person doing the handling and result in musculoskeletal ill health. And then from the extremes in terms of temperature, again, there we would look at the type of activity. It's not as straightforward as saying, 12 degrees is extreme. It's very much based on the activity. So we generally look at, there is ergonomic guidance there for each individual workplace. But for, say, for warehouse activities, you're looking at about 16 and a half degrees. But if it's freezing cold and someone has to wear gloves and to counteract the freezing cold, or indeed it's extreme in terms of very high temperatures and someone is sweating, well, of course, then that's going to affect the person's grip, their tiredness, their ability to handle loads for longer distances. That's why we're considering the extremes of environmental side of things. If you're unsure, please just to ask. There's no issue at all. Contact us here at lce.ie.
Thanks, Ita. Another question here for you as well, and it's from Anya. And Anya would want to know is, would the wearing of jewellery be a consideration in the risk assessment as per the gentleman in the video of the lift from the pallet to the conveyor belt?
Okay, a very good observation, I would say, Anya. So what we're assessing here is the musculoskeletal risk, or the risk associated with the musculoskeletal health. And if the wearing of jewellery, it's unlikely to affect the musculoskeletal health. However, it is a safety issue. So if someone is carrying a load and it's got sharp edges, there's a potential for rings to get caught in the load or whatever else. Absolutely, we need to consider that, but we don't rate it in terms of the MAC assessment, but it certainly should be captured as part of either that risk assessment or a safety risk assessment where the jewellery could result in an injury. Hopefully that answers your question, Anya.
That's great, Ita, and thanks very much, Anthony, as well. Frank, that's the last of the questions I have here, so I'm going to hand back to you, and thanks for the panelists and for everybody who asked questions.
Yeah, thank you very much for that, Barry, and thank you for the questions. They're very, very useful for us as well to get an insight to kind of queries people have. Okay, so look at I just want to thank Anthony and Ita for their presentations this morning, and they were all very interesting. And most importantly, just to thank yourselves for attending the webinar today. Just in terms of just wrapping up, just be aware, as I said, the survey, we would appreciate it if you completed the survey after you sign out. And also just to be aware that there will be recordings of all our webinars over the last 3 to 4 weeks on the HSA website. So keep an eye on that. They should be uploaded within the next 2 weeks. So without further ado, I'll just say goodbye and thank you very much again to everybody, and have a good day. Thank you very much. Bye-bye.
Thank you. Thank you.